This program is brought to you by Emory University.
Good morning. Welcome to Cardiovascular Grand Rounds. This morning's speaker is Dr. Raja Laskar. Raja grew up in Clemson, where his parents were both professors, and he's not here to talk about national championship football today, but he attended medical school at Emory and then did his training at UT Southwestern. He's been a valued leader and colleague with our advanced heart failure team. He's a medical director of our mechanical circulatory assist program, and he's associate professor of medicine, and he'll be speaking today about contemporary controversies in heart failure.
All right, and thank you for coming here this morning on the last Grand Rounds of the year. I thought I'd talk about some controversies or updates in advanced heart failure through the lens of one patient's story. So there's a heart failure patient. It's a long story and it's going to be a sad story, but it does illustrate a lot of the things that we deal with in the advanced heart failure world. I'm a little nervous up here talking to my colleagues. It's the last Grand Rounds of the year, but recently I gave a talk where I was a lot more nervous. This was at my first grader's career day, and I know you guys are skeptical, but first graders are very skeptical, and it's hard to hold their attention for 1 minute, let alone 10 minutes. They learned about being a heart failure doctor and a cardiologist, and these are some savvy children, so they asked some good questions about my profession. And so they asked me, do you stop heart attacks? And I said, no, not really. Do you know any procedures? Not do you do any procedures? No, I don't know any procedures. Do you do surgery? I do not do surgery. And do you shock people's hearts? That was their last question. I said, no, I don't do that, but I am a heart failure doctor, so what do I do? And I make, and our colleagues make, difficult clinical decisions with very little clinical data to guide our decisions. So they really were not very impressed with my answer. So, at the end of it, they vote on what profession they'd want to be, and I think I was next to last. So there was an insurance salesman who had a worse job than I did. So I'll start with our patient who we've been taking care of in our group for over 6 or 7 years. This is a 31-year-old female who came to our care in 2011, and she was transferred from an outside hospital for advanced therapy options. She was originally diagnosed with heart failure in 2010, and she developed a peripartum cardiomyopathy after her second pregnancy. And over at the outside hospital, she was treated for about a year and had a worsening of her heart failure and was subsequently transferred to our hospital. When we saw her, she was quite ill. She had a blood pressure of 118/86, a heart rate of 104. Her JVP was about 12 centimeters, and she had a 2/6 holosystolic murmur and a soft S3. Her medical regimen was minimal, but sounds like that's as much as they could get her on, which was toprol 25, isosorbide 60, hydralazine 10 milligrams, and Lasix 80 milligrams. So after we stabilized her, after a couple of days in the hospital, she had a lot of long-term questions about her care and her prognosis. This is a young woman who had just recently become sick over the last year. And certainly, initially, she's had several high-risk clinical risk factors. She had a resting tachycardia, heart rate above 100. She was not able to tolerate high doses of beta blocker. Toprol XL of 25 is certainly lower than our target dose. And she was congested on physical exam. Even at the end of her hospital stay, she had signs of congestion. Most importantly, she had peripartum cardiomyopathy, where there are few diseases that devastate young people to such a degree with limited answers on what the right treatment or what the prognosis is, and certainly in cardiology. It remains a clinical enigma. It's got an unclear incidence, even in 2017. There are certain areas of the world where there's a much higher prevalence of peripartum cardiomyopathy that may be nutritionally related. In some third world parts of the world, the incidence of peripartum cardiomyopathy is quite high. It is a heterogeneous disease, and there are likely some patients who are labeled peripartum cardiomyopathy who have severe preeclampsia, who develop some LV dysfunction, some patients who have pre-existing LV dysfunction who becomes manifest when they become pregnant. And there are certainly some patients who have true peripartum cardiomyopathy or an idiopathic cardiomyopathy that develops during pregnancy. Some of the risk factors that have been shown in small registries are older age, African descent, if you have a history of preeclampsia and hypertension, and multiple pregnancies. The etiologies for this idiopathic cardiomyopathy, again, are not well determined, but recently it has become one possible etiology is a genetic predisposition to developing peripartum cardiomyopathy, and that was shown in a couple of slides in a minute. As far as the unclear incidence of peripartum cardiomyopathy, it can vary quite a bit in that it is hard to get a number of the true risk or incidence of that. And these are different databases in different hospital or birth rate numbers, and it can vary between 25 and all the way up to 100 live births out of 100,000 live births. And again, in certain parts of the world, that number is significantly higher. So when we counsel a patient after they've developed this disease, we have a hard time telling them this is very uncommon. We don't have a number that we can give them as what their real risk is. A frequent question that comes up in a young female who develops this is, what are my chances of this worsening if I become pregnant again? And it's through mostly anecdotal data. It certainly appears that if you have persistent LV dysfunction and you have symptomatic heart failure, your risk of subsequent pregnancy is very high. Almost half of those patients have further deterioration in LV function. They may or may not survive pregnancy, and even if they do, they will have likely a poor long-term outcome. If you have complete recovery, or if you have LV dysfunction that improves after a year or so, either of therapy or just through potentially the natural history of this, you still have there's still a risk of pregnancy after that. There's at least a 1 in 5 risk of relapse of LV dysfunction if you have a subsequent pregnancy. So there's still a little bit of amorphous data because there's some women who can undergo pregnancy successfully if they have complete recovery. We have difficulty determining those patients, and frequently, as we all know, patients don't listen to us and they become pregnant against our advice. And what are the risks of that? They do need careful and close monitoring, but beyond that, we don't have many recommendations for those patients. What's certainly becoming more clear is that there may be a genetic predisposition in patients who have peripartum or dilated cardiomyopathies. This was an elegant paper that was published last year in the New England Journal that looked at patients who had a peripartum cardiomyopathy through a number of different cohorts, a total of about 170 patients. And in that group of patients who had peripartum cardiomyopathy, about 15% were found to have a genetic predisposition, if you will, of having genes that subsequently are known to be risk factors for forming a dilated cardiomyopathy. The general prevalence of that in the general population is about 4%, and in a dilated cardiomyopathy, idiopathic dilated cardiomyopathy prevalence, that's about 17%. So it's mimicking the percentage of patients who develop a dilated cardiomyopathy. So there's definitely at least a portion of these patients who may have just a genetic predisposition, and through the risk of pregnancy, they develop or manifest their dilated cardiomyopathy. But at the end of the day, with peripartum cardiomyopathy, there's just a big need for additional data. This is the concluding paragraph of a recent circulation review of peripartum cardiomyopathy, and this is worth reading. First, in the light of relatively rare nature of peripartum cardiomyopathy, multi-center collaborations and registries are urgently needed. A registry that began in 2012 has thus far only gotten 100 patients in the registry, half from Africa and only a handful from the United States. Secondly, further research support is needed. Currently, the NIH does not support a single project that studies peripartum cardiomyopathy. Third, Organized patient advocacy groups would help galvanize support and recruit subjects for research. No such group currently exists. Advancement in the understanding of peripartum cardiomyopathy is at an inflection point. With appropriate coordinated efforts, progress in the next few years will be exponential, and translation to the clinic will become a reality. So our long-term patient, she was thankfully not interested in having more children. She had a pretty severe cardiomyopathy, and that would certainly put her at risk for worsening heart failure. Despite close clinic follow-up, adjustment of diuretics, and prophylactic ICD implant, she became more ill over the next 18 months or so. And eventually she was admitted to our hospital for low-output heart failure in early 2013. She had a prolonged hospitalization, about 10 days, and she underwent an inpatient transplant LVAD evaluation. She did require IV inotropic support during that stay, but after diuresis and a very aggressive care, she was able to be weaned from inotropes. So during our heart transplant evaluation, we have a lot of people see our potential candidates, including our social worker, our psychiatrist, financial counselors. We do an in-depth medical assessment, and she was deemed to be a poor candidate for heart transplant based on a number of factors. One, she was too obese. Our BMI cutoff for transplant is 35. Her BMI between different clinical notes was between 37 and 44. She had psychosocial concerns. We'll get into that for a minute. And she was not inotrope dependent. So the ISHLT guidelines for obesity are fairly clear. A pre-transplant BMI of greater than 35 is associated with worse outcomes after cardiac transplantation. For such obese patients, it's reasonable to recommend weight loss if they can, to get a BMI below 35 before listing for cardiac transplantation. So it's interesting, when you look at the data for obesity, it is a relative contraindication. If you look at other risk factors, medical risk factors for transplant, others are much more significant as far as 1-year operative mortality and 5-year survival. And so, for example, patients who have severe peripheral vascular disease or patients who have severe diabetes with multiple complications, that carries with it a more severe risk than obesity. In obese patients, not surprisingly, because of donor matching, it increases the wait times for transplant quite a bit. And there is a modestly increased risk for early surgical risk, and an increased risk, not surprisingly, of developing long-term metabolic complications of diabetes and coronary artery disease at 5 to 6 years. But again, does not carry the same risk, for example, as somebody who has severe diabetes with vascular complications. It's also a reminder that Americans are becoming more obese. This is from NHANES data from the mid-70s to 2004, and the population distribution of BMI. And again, this is up to 2004, and this is not the state of Georgia, where this curve is probably a little bit more to the left. But you can see there's a sizable percentage of patients who have a very elevated BMI, even in 2004, and that's not changing. You can also see that in the NFL. On the left is the great Randy White, a Hall of Famer defensive tackle, where the average weight of defensive tackles in the 1970s was about 270. That's B.J. Raji from the Green Bay Packers, who's where the average weight now in the 2016-2017 is about 320 in that position in the NFL. So even in sports, you can see the changing demographic that we deal with. So there's not much data, not too many programs transplant patients who are morbidly obese or have a BMI of greater than 35. This is probably the largest cohort, and it's an older data set published in 2010. And you'll see in the obesity, the morbidly obese arm, those folks who have a BMI of greater than 35, their 1-year survival is pretty similar to patients who have only mild obesity. Where you really get into complications are in those patients who have a 5-year, their 5-year outlook is worse than those patients who have a normal weight. So so in that sense, there are some centers that do transplant patients who are morbidly obese and very carefully selected patients, and there's an argument to do that because at least the 1-year surgical mortality is not prohibitive. Obesity clearly delays eventual transplantation. Again, That's largely due to donor matching. You can't simply put in a patient who's 70 kilograms, a donor heart of a patient who's 70 kilograms into somebody who's 130 kilograms. They will have a much higher risk of perioperative complications. This is the time to transplant stratified by BMI, and you can see those patients who have a BMI of greater than 35 have a much lower rate of transplantation within 1 year. So frequently, given the dearth of heart transplants and the prolonged waiting times anyway of our patients, most programs do not list patients for heart transplant if they have a BMI of greater than 35 for a myriad of reasons, but it is a relative contraindication, if you will. So what about our patient psychosocial evaluation? A lot of our transplant evaluation is trying to see if they can do the things that we ask them to do after transplant. Do they have a way of coming back and forth as frequently as they need to for their care? Can they get the medicines? Can they afford their medicines for their care? Can they, again, do the things that we ask them to do? And our patient really had limited financial resources, limited social support. She is able to come to clinic but had sporadic compliance, as we'll document. And really the question becomes, besides our gut feel for how a patient can do with their psychosocial support, can we quantify this? And there is more data coming out because this is certainly an area of interest in the heart failure world. And only a heart failure doctor would cite a psychosomatic medicine journal for cardiovascular rounds. But this is a recent psychosocial assessment tool that we use in our group that looks at the prospective study of medical and psychosocial outcomes. It was developed at Stanford and validated in their cohort, and there's certainly a lot of interest in different groups to try to validate this within their cohort. And it looks at kind of different psychosocial domains, and some of this may not show up that well, but it looks at understanding of disease, ability to understanding of how sick you are, your ability to deal with stress, and your history of substance abuse. And it's really a comprehensive tool to try to assess that, and we have multiple people who score. So our social worker will give a score, our financial person will give a score, and our psychiatry team will give a score, and we come up with a score between 0 and 44. 0 is a good score. 0 means that you have very low risk of psychosocial complications post-heart transplant or post-LVAD. A score that's above 20 is high risk, and there's not that much data, prospective data on this. This is from the Stanford group in the original paper. And what they did see is that if you had a high score, greater than 20, you did have a higher risk of complications of non-adherent psychiatric complications and a higher risk of medical rehospitalization. So not surprisingly, if you're struggling to deal with a severe chronic disease before transplant, after transplant, it's a complicated care course, you can get into similar issues of adherence and medical rehospitalization. So in our patient score actually turned out to be in the 30s, so would be at a high risk or minimally acceptable for transplant. And it's interesting that even though we can get LVADs off the shelf, there's not a delay in surgery typically, our transplant social support requirements are less than what's required for an LVAD. As we frequently talk to house staff about, after transplant, after you've recovered from surgery, and after you're doing better, you can return to work in many circumstances. Your transplant care is mainly coming back for procedures and follow-up and making sure you take your medicines properly, and a few specific instructions. With LVAD, you have dressing changes that you have to do on an every other day basis. There is understanding of equipment that you need to understand. There may be times where you can become very debilitated even after you've recovered from surgery, so that there are more social requirements required for that. And that's so even though it is something that we don't necessarily have to delay therapy for like we do with transplant, those requirements are generally higher than those patients who are potential LVAD recipients. So our patient, it was technically too well for LVAD or transplant, given that she wasn't inotrope dependent. And she was not a great candidate for either therapy, given that she had suboptimal psychosocial factors. And also, again, she was too well, even though she was quite ill from a heart failure standpoint. So do we have any other non-medical options, or do we simply continue to follow her in the clinic and try to do our best from keeping her out of hospital? Well, this is her echocardiogram. It's not the best quality echo, but this is her LV, and LV is quite dilated. Her LV measures to about 8.5 centimeters. You can see that her valve, her anterior posterior leaflets are kind of shifted up, and she does have a high tenting angle, which we'll talk about. And she has a lot of mitral valve regurgitation. And she has severe functional mitral valve regurgitation. So one potential treatment strategy is to try to deal with that in a procedural fashion. So the definition of functional mitral valve regurgitation is mitral valve regurgitation, which occurs in the absence of structural pathology of the mitral valve leaflets, the annulus, chordae, and papillary muscles. It occurs both in ischemic cardiomyopathy, those patients who have an inferior posterior MI, and also in non-ischemic dilated cardiomyopathy patients like our patient. So this is, of course, a diagram of the mitral valve, and by definition, there is not a problem by either the anterior mitral valve leaflet, the posterior leaflet, the chordae, or the papillary muscles. It is simply a function of the LV. These are two diagrams of both the functional ischemic MR variety and the non-ischemic variety. And in the ischemic variety, of course, the inferior posterior wall is infarcted or is ischemic. The papillary muscle is dysfunctional, and you have a tethered posterior leaflet that's fixed, and through that you will have MR that can be posteriorly directed. In our patients who have a severe functional mitral valve regurgitation from dilated cardiomyopathy, their LV becomes more spherical, the papillary leaflets become spread out, and the valve regurgitation is more central. And that's predominantly would be the argument to try to fix the mitral valve in this patient who has severe functional mitral regurgitation, even though there's not a mitral valve leaflet pathology. So the echo differences between these two types of functional MR, in our patient who has symmetric mitral valve regurgitation, both leaflets are tethered and displaced. The tenting angle is markedly increased. The annulus is dilated, and there's global dilatation with increased sphericity of the LV. The MR jet is typically central. In the ischemic MR, as we all know, it's usually inferior posterior MI. Most commonly, the posterior leaflet is tethered, and there's a tenting angle that's increased but not necessarily markedly increased. So the prerequisites in dilated cardiomyopathy for functional MR is, number one, a dilated annulus, decreased LV systolic function, displaced papillary muscles, or spread out papillary muscles, if you will, an increased left atrial pressure, and there's certainly, in patients who have a left bundle branch block, there's a conduction abnormalities can contribute to functional MR as well. The tenting angle, or there are opposing forces in closing the mitral valve. The mitral annulus needs to be dilated. The leaflets are pulled up because the papillary muscle is displaced and is less functional. So there's a higher force that's pulling that back, and that leads to both leaflets being pushed up like this. And you can actually measure this angle here, and for the mitral valve clip cases, our echocardiographers do measure that as a way of predicting whether or not there will be an improvement in LV function, or if it's safe to do a mitral valve clipping, because that tenting angle does is one of the things that can is one of the procedural risk factors. So this is that angle here where the leaflets are pulled up, and that area there can be predictive of procedural success. LV sphericity is also a primary factor in non-ischemic functional MR. Again, it leads to lateral and apical displacement of the papillary muscles, and those patients who have a very round LV have a higher likelihood of developing functional mitral valve regurgitation. And at the end of the day, with a dilated or a non-ischemic functional MR, the question is it a chicken or egg problem? There's certainly, it is predictive if you do have functional MR that you have a worse prognosis with a dilated cardiomyopathy. It is predictive of worse outcomes, but can we modify that? What came first? So we'll spend a couple of minutes looking at the potential benefits of limiting functional MR and exploring whether there is a role for surgical or percutaneous mitral valve repair. Clearly, in multiple data sets, if you do have functional MR due to dilated non-ischemic cardiomyopathy, your prognosis is worse. This is from the Duke database looking at ischemic and non-ischemic cardiomyopathy. And if you have severe functional MR, your prognosis, even adjusting for other risk factors, is significantly worse than if you don't have functional MR. And that's true both in ischemic and non-ischemic cardiomyopathy. The first therapy to try to fix this is simply pharmacologic improvement of intracardiac filling pressure, simply unloading the LV and hopefully shrinking a little bit. And decreases in LV dilatation and left atrial pressures can have been shown to improve the dynamic nature of the regurgitant orifice area and decompensated heart failure. So simply getting that patient as optimized as possible can improve functional mitral valve regurgitation. And classic studies from the 1980s, 1990s of tailored hemodynamic therapy clearly showed that you can decrease the amount of mitral valve regurgitation, again, simply with vasodilator therapy and diuretics. CRT, of course, can also improve functional mitral valve regurgitation. This data is from the CARE-HF study, which looked at CRT and dilated cardiomyopathy, kind of the mortality, the study that really showed a mortality benefit in these patients. And in this study, there was a remodeling effect over time, and you can see that the mitral valve regurgitation area improved quite markedly over time and over a year and a half period of time. So suggesting that long-term, which definitely shows that long-term remodeling of the LV, if you can shrink the LV through whatever therapy you institute, you can improve functional mitral valve regurgitation. So what about trying to actually fix the mitral valve, either surgically or percutaneously? And there's certainly been a lot of interest in that among surgeons and the cardiology community. And these are the randomized controlled trials in mitral valve surgery in functional dilated cardiomyopathy. There really is not much data. There's not any data that's really randomized and controlled. There is some suggestions and some information that's out there in patients who have ischemic functional mitral valve regurgitation. This again is from the Duke database looking at ischemic cardiomyopathy. And the first question is still the main question is what came first, the chicken or the egg? What came first, functional MR or really terrible ischemic cardiomyopathy? And this data suggests that not only if you have functional MR, your prognosis is worse, but if you try to fix it, maybe some utility in trying to fix it. This is looking at, again, their retrospective cohort of looking at patients who were treated medically, treated with coronary bypass surgery and valve disease. And you can see that those patients who were treated medically, and if you had ischemic MR and coronary artery disease, your survival was significantly worse than if you underwent valve surgery or coronary bypass surgery, which was significantly better. Again, suggesting that maybe there is a rationale for this, but again, this is retrospective data and fraught with all kinds of biases. There's certainly been some prospective good data from looking at mitral valve repair versus replacement in the CTSN network. This is ischemic mitral valve regurgitation, again, different from our patient, but in this cohort, trying to figure out, in this randomized trial, trying to figure out whether mitral valve repair or mitral valve replacement is beneficial in these patients. Turns out that everyone suspected, the surgeon certainly suspected that mitral valve replacement would be a better therapy in these patients than mitral valve repair. Not surprisingly, those patients who underwent mitral valve replacement did have a higher perioperative mortality compared to mitral valve repair. And in this cohort, it was a wash, but that was in large part due to early perioperative mortality in the mitral valve replacement arm. At 1 year, however, those patients, not surprisingly, if you had a mitral valve replacement, you had cured their mitral valve disease. Their risk of recurrent MR was quite low in compared to the repair arm. So, and there is an argument that this study did not answer the question, but in those advocates for mitral valve replacement, the argument would be that long term, if they do well with surgery, you have hopefully gotten rid of their mitral valve regurgitation, because there is certainly a high risk of recurrent mitral valve regurgitation with a mitral valve repair. What about structural heart devices? And certainly the mitral clip has been around for quite some time. It's tried and true, at least procedurally. And as our proceduralists have become, and our structural heart team has become better equipped, and they have felt at least comfortable approaching patients like our patient for these procedures after a lot of cajoling and bribing by our team. But it can be done with in patients even as ill as our patient. So the FDA has approved the mitral valve clip for inoperable patients with degenerative mitral valve disease since 2013. There is some use of the mitral valve clip beyond the classic Everest criteria, and there is an ongoing trial, the COAPT trial, for patients like our patient, although they probably were too ill for that trial, to be randomized in this trial. What's certainly been clear in large cohorts is that the acute procedural success, which was originally a question in the late 2000s, has been achieved, and this is across multiple different registries and studies. And you can see on the left the procedural successes of these trials is above 95% in most of these studies, and the initial decrease in mitral valve regurgitation is quite substantial. And for patients like ours, there is data that's going to be coming in the COAPT trial and the Reshape Heart Failure trial and the MITRA trial as well, fairly large cohorts of patients who have EFs as low as 20 and 15%, who are not appropriate for surgical mitral valve surgery, surgical mitral valve replacement. And so we will get real data to say whether mitral valve clipping would be beneficial in these patients. There are also transcatheter mitral valve replacements that are on the horizon as well. At Emory, we've done a few of the Tendyne valves, and there are other valves out there that are in clinical development. So there are at least procedurally ways of fixing the mitral valve, theoretically in a less morbid and less high-risk fashion. So our patient, after promising to give up my first born child to Dr. Babayeros, did get a mitral valve clipping. And this is her procedural result after the procedure. And her LV is still quite enlarged. Her MR did go from severe functional mitral valve regurgitation to probably mild in some other views. And she had at least initially a reasonable peri-procedural result. But, as in all things in heart failure, it's not always a happy story. Post-procedure, about a few months later, she did have worsening severe MR, and she has had recurrent multiple heart failure admissions. And the 2 years after her clipping procedure, she had about 5 admissions for heart failure. So Dr. Babayaris is keeping my firstborn child. Each admission, she has been responding to IV diuretics, but she is able to be discharged within a matter of a few days. And we were struggling on how best to treat her, given that she had recurrent heart failure hospitalizations. A few days in the hospital, she gets better. She's clearly still congested, but we try to arrange for close follow-up. And so the question came up, can we come up with something else to try, from an outpatient standpoint, to decrease her risk of readmission to hospital? We've already tried to improve her mitral valve disease, and to not much avail. So there are new strategies to detect and measure pulmonary artery pressures remotely, and the idea being that we can detect heart failure decompensations before patients come to clinic and before they become symptomatic. And this is, of course, the CardioMEMS device, which was originally the procedural paper was published in 2007, where you can safely implant a remote sensor in a branch of the pulmonary artery through a right heart catheterization. It has been shown to be safe short-term and long-term procedurally. It does not seem to increase the risk of pulmonary artery damage or pulmonary embolus. Patients do need to be on typically dual antiplatelet therapy for a short period of time. The seminal study was published in Lancet in 2011, which was a randomized controlled trial where patients were randomized to getting the device or not getting the device. It is a small device, and again, the procedural risks were quite small in the trial data. It was a multi-center, single-blind clinical trial. Patients were sick. They needed to be admitted within the last 12 months and needed to have heart failure symptoms within the last 3 months. And it was a rather large cohort of about 550 patients. The hemodynamic guided therapy was guidelines for clinicians in a sense. They were told to try to achieve optivolemia by any means necessary. Optivolemic meant improved symptoms, relatively normal PA pressures, and if patients were different but still optivolemic, the investigator could alter the range for an individual patient. So in other words, not every patient will feel better with a right atrial, with a PA diastolic pressure in the teens. So those patients the investigator may have elected to have a higher PA pressure to shoot for. This is what we get when one of our patients has these devices. This is the estimated PA pressure tracings of the systolic and the diastolic and the mean PA pressures, and you can see this patient's PA pressures are quite elevated. The N is where we made an intervention, so we saw a trend towards elevation of their intracardiac filling pressures and probably made an adjustment in diuretics. And again, we see a trend here and a trend here, and we're attempting to make an intervention before they have symptomatic heart failure and hopefully before they have decompensated heart failure. So it does require that the patient download data on a daily basis, and it does require a patient to be responsive to PO diuretics, not necessarily stage D heart failure. So those are the patients who we think benefit from these type of devices. The results of this data was pretty remarkable. It did show almost a 30% reduction in heart failure hospitalizations in the control group versus the treatment arm. And it had a pretty low serious adverse event rate, and it's, again, procedurally and short and long term, it did appear to be safe. In other words, there weren't very many pulmonary emboluses at all or things like that. The limitations were that patients were not masked. If you had the device, you got more frequent phone calls, more frequent adjustment of diuretics, and that particular issue, along with some issues with data, led to almost a 3 or 4 year delay in FDA approval for the device. It wasn't based on efficacy and not safety. Their concern was based on efficacy and not safety concerns. in particular that the patients who had the device got much more frequent interventions. But it certainly it is now FDA approved, and that being said, there are certainly a few barriers to continue to be a few barriers to therapy. First is cost is certainly a barrier for all of us and commercial carriers. The device itself is estimated to be about $17,000. There's a modest implantation procedure fee, and but it has been shown to decrease heart failure hospitalizations, which depends on how you cost it out, can be as high as $20,000. So the cost-benefit analysis depends on which has been shown to be beneficial if you use the Champion data set. This is recent data that's come out that looks at the real-world usage of this data, of this device. This was looking at a cohort of patients that use their own pre-implant heart failure hospitalization rate, and then looking at them post-implant using Medicare claim forms. So it's a large cohort of about 1,000 patients. The blue arm is the patients before they are hospitalized, before they had the CardioMEMS device. The red arm is the arm after they have had the CardioMEMS device. And you can see in this rough data set that the heart failure hospitalization rate has gone down quite significantly in this large cohort of patients using themselves as their own control. This is the data looking at it non-graphically, and you can see that the heart failure hospitalizations the number of heart failure hospitalizations has decreased quite remarkably in this cohort of about 1,000 patients. And based on this data, it is cost-effective given the marked decrease in the number of heart failure hospitalizations. So at least from a clinical trial standpoint and in a real-world standpoint, in the appropriate patient, CardioMEMS devices can reduce heart failure hospitalizations. It is likely cost-effective in the appropriate patient. The real-world data was impressive. Again, it's not the best data. It's based on Medicare claims, and it's not randomized, but it is impressive. So the likely patient profile that benefits from these devices are those patients who are not necessarily stage D, who are diuretic responsive, and are really able to follow our instructions. And all three of those things are unlike our patient in a sense, but we still elected to put the device in. Our patient had a successful implant and went home the same day. Her feeling pressures at that time were reasonable. Her right atrial pressure was 5. Her wedge pressure was 12, and her cardiac output was 4. Unfortunately, as in all things heart failure, it's a sad story. She stopped transmitting regularly when she had some phone issues, and even though the device has been put in about 2 years ago, she has only sporadically been providing us data, and she continues to have frequent heart failure admissions, and frequently they are short-term admissions where we can give her a few days of diuretics and she improves. So this device, in theory, could have helped her, but in the appropriate patients, it can improve outcomes as has been documented. So her question is not infrequently is, can you give me something else besides IV diuretics, because it's the same song and dance for the last few of her hospitalizations. And there are, of course, a number of treatments that improve outcomes in chronic heart failure. Obviously, beta blockers, ACE inhibitors, aldosterone antagonists, defibrillators, CRT therapy, isodiol hydralazine, and sacubitril ARBs. But treatments that have been shown to improve outcomes in acute systolic heart failure is 0. So that's despite a lot of pharmacologic interest and obviously cardiology interest in trying to develop adjunctive therapies for decompensated heart failure. And pharmaceutical companies have spent tens of millions of dollars into trying to develop an adjunctive therapy for diuretics as a way of trying to get patients home sooner and hopefully prevent recurrent hospitalizations. And the landscape is littered with failed clinical trials of both of these agents listed here, of both agents that are novel or agents that have been shown to be beneficial in other circumstances. And all of these studies, from nasiratide to tolvaptan to high-dose spironolactone, have all been shown not to benefit patients in acute heart failure. There was recently some excitement about serelaxin and other nasiratide-like agents in acute heart failure, and the phase 1, phase 2 clinical data was promising to not only show an improvement in acute hemodynamics, but potentially even an improvement in mortality data. But those trials, including olatoride, I can't say that right, did not show a benefit in heart failure outcomes early and late. And it's interesting that many of the recent clinical trials were looking, in particularly this clinical trial, was looking at a very short-term infusion of drug when a patient came in with acute heart failure, and then trying to determine whether or not the morbidity mortality was improved, not at a week, not at a month, but months down the road. And that's a pretty hard lift for an acute heart failure drug. And there's a lot of discussion within the clinical trial community in heart failure. It's like, what are we doing? Because why are these trials looking at long-term outcomes when these are really short-term medications? This is looking at the study drug infusion, and at least there's a suggestion that with olatoride that there is a decrease in acute complications with this drug in comparison to high-dose diuretics. And there's probably some utility in trying to shift our focus and trying to be a little bit more humble with these drugs and trying to see if something can decrease acute heart failure complications within a week period of time with this drug and some of the serelaxin derivatives. So with this patient, is there anything else that we can do to adjust her chronic heart failure medications? She is currently on a pretty high doses of diuretics. She's on torsemide 100 once a day, sometimes twice a day. She takes metolazone twice weekly. She's on a very modest dose of beta blocker, toprol 25, lisinopril 5, aldactone 25. And are there any other drugs that are available that could benefit her, not from a mortality standpoint, but from a morbidity standpoint? And of course, if you haven't heard about this drug, it's out there in the lay press. This is Entresto, which will help make tomorrow possible. It is a drug that certainly is in the appropriate patient is one of our armamentarium, which it should replace ACE inhibitors and ARBs in new onset heart failure. In patients who have established heart failure, we are converting some of those patients in the appropriate population, but it's now a class 1 indication to start this medicine for patients who have a new onset cardiomyopathy. This particular slide has been at a heart failure conference is shown about 55 times. This is from the Paradigm HF trial, which shows that the primary endpoint of Entresto in comparison to enalapril in contemporary pharmacologic therapy for heart failure showed a marked benefit in mortality, heart failure hospitalizations over time. And if you just look at heart failure hospitalizations and just focus on that endpoint, there's a marked decrease in heart failure hospitalizations, even by 6 months and certainly by a year in those patients who are treated with Entresto or sacubitril ARB combination in comparison to ACE inhibitors. So it is a drug that does decrease heart failure hospitalizations over time, where some of the cost effectiveness needs to be factored in. But obviously cost is an issue for many patients, and enalapril or lisinopril is in some pharmacies is given away free in comparison to Entresto, which without a pharmacy benefit or Part D or a insurance coverage is $400 a month for that drug. So that can be a prohibitive issue for many of our patients. Dr. Morris and Dr. Dickert and Dr. Shore are interested in trying to see how we approach that with patients like our patient who is strapped financially, and trying to discuss with them how to approach them to try to switch them to a better medication. This is kind of a patient-centered way of looking at this is the potential benefit that you would have if we give you this drug that's very expensive, not very expensive, but compared to zero is very expensive. And this is looking at what your potential benefit is from a mortality standpoint, that there is a benefit with this drug, but when you look at it from a population standpoint, but from an individual standpoint, may not be as big a benefit, particularly in comparison to the costs that it will require for this patient. So you do have a mortality benefit, but over 2 years, 17 out of 100 people died on Entresto over 2 years, compared to those patients on lisinopril, where 20 out of 100 patients died over 2 years. So they are currently looking at how best to approach patients like this, and they're in the midst of doing some very interesting, gathering very interesting data on this. So our patient has continued to struggle. In many ways, when I discussed with my colleagues, I was going to talk about our patient, like, she's still alive. Yes, she's still alive. She is fortunate to survive for 7 years. She continues to have frequent readmissions despite all the therapy that we've tried to do for her. CardioMEMS device, the mitral valve clip, and really aggressive access to care with frequent phone calls and everything. In the last 7 years, she's had a lot of utilization of resources. That's one way to say it, right? 15 hospitalizations, 40 office visits, a number of echocardiograms, and a number of right heart catheterizations, in addition to the mitral valve clip and the CardioMEMS device implant. So what are some take-homes with this long story? Well, first, not surprisingly, if you have advanced heart failure, it's not just a highly high mortality disease, but it's a highly morbid disease. Peripartum cardiomyopathy, to me, remains a mystery, even though we take care of a number of these patients. They're certainly becoming more understanding that there's likely a genetic component for a portion of these patients. It really has unclear outcomes with limited data, and we do need a huge need for multi-center registries, given the limited number of these patients and that they're not always concentrated in one clinical setting. Percutaneous mitral valve therapy for systolic heart failure, again, the dilated cardiomyopathy variety, really should occur in the context of clinical trials. Our patient got this device almost in a compassionate use standpoint, but for the majority of these patients, they should be randomized in the COAPT study, given the limited clinical benefit and data for our patients. Remote pulmonary artery pressure monitoring for heart failure certainly has promise, and the CHAMPION data and now the clinical real-world data is very promising of in the appropriate patient, again, those patients who are diuretic responsive, who are not stage D but are stage C, those patients may benefit from a CardioMEMS device. The recent trials in acute heart failure therapy have been neutral and have been very disappointing, again, despite multiple large clinical trials and multiple significant amount of pharmacologic interest in this area. Entresto certainly is the most important drug that's been developed in chronic heart failure in decades, and it does have a morbidity and mortality advantage over ACE inhibitor for chronic heart failure therapy. And the final take-home is from an anonymous heart failure attending. You probably can guess who it is that you really can't make chicken salad out of chicken poop. Was probably the lesson from this talk. So thank you very much, and I'll be happy to entertain any questions.
Right, just a reminder to use the microphone when you ask a question. And at 9 o'clock today, Mike Burke will be giving the cardiology biology seminar, and we'll be talking about genetics and epigenetics. Mike, I assume you would have a solution for this patient to reverse the myocyte abnormalities. Raja, let me just ask a question. That this patient was obese, and as far as the role of obesity in the issues related to recurrent fluid, thoughts about whether any types of obesity therapies might potentially be a benefit?
So I don't think we can try more therapies on this patient that are likely to work or not likely to work. So there's certainly the obesity paradox in heart failure patients. Those patients who are severely malnourished have a very low BMI, not surprisingly, have a worse long-term prognosis. Those patients who have more stage C heart failure and have more obesity or morbid obesity have a better prognosis than those types of patients. There likely is a phenotype of patients who have true morbid obesity and they have a cardiomyopathy related to that. And with aggressive weight loss, either through gastric bypass surgery or just aggressive weight loss, we have seen anecdotally patients improve their LV function in those patients. And in those patients, it's not just a volume status control, but they do get true LV remodeling. Patients who've been on medical therapy for a long period of time are morbidly obese, that improves and their LV function improves, and that's not really well understood why that happens, but there is certainly a small cohort of patients who that type of therapy can be beneficial.
Superb talk. A couple of questions. One is that the dictum has been in the past that if you have mitral regurg and you close the mitral regurg, your EF falls because you've lost one of your escape valves. Do you encounter this when you're doing clipping?
That's certainly one of the risks and one of the thoughts that has led many patients, many cardiologists, heart failure, structural, and all the above, to be concerned about that. I think in this patient, she was in a desperate circumstance and trying anything. The patients that I suspect would be reasonable candidates for this is definitely whatever. My thoughts are those patients who have hemodynamics that are not awful, who are not in low output heart failure, but have almost mitral valve regurgitation out of proportion to their hemodynamics, where their left atrial pressure is not 25, but it's 15, and they are not necessarily 8 centimeters, or maybe 7 centimeters, and who are not at time zero a transplant or LVAD candidate and potentially could benefit from some sort of mitral valve procedure. There's no data to support that, but I think those patients who don't do well with this are those patients who are in low output type of heart failure, who have very elevated left atrial pressures despite everything that we're doing. Those patients by definition have end stage heart failure and probably wouldn't benefit from percutaneous mitral valve procedure, whatever that is, in 2017.
Just give me one other question. Was that also that you were, as you looked at this, you said repair was not as good as replacement. Now that also seems to go against the previous data. Are you talking about just a particular group of people?
So this was from a signal from the CTSD, the ischemic cardiomyopathy trial with MR, looking at mitral valve repair versus mitral valve replacement. In that cohort, in that randomized clinical trial, the patients who had there was not a statistically difference in survival. There was a higher perioperative mortality with mitral valve replacement, but at year one, there was a higher degree of mitral valve regurgitation in the mitral valve repair patients, not surprisingly. So that there's an argument to be made that one strategy in these severe cardiomyopathy patients that mild mitral valve regurgitation will eventually turn to moderate to severe mitral valve regurgitation as the disease progresses. Why not try to replace the valve theoretically percutaneously? Then that removes a chance of worsening mitral valve regurgitation down the road.
As long as we're talking about how many gadgets you can put in this patient, there's another new gadget goes in the atrial septum, kind of a pop-off valve that's being evaluated. I wonder whether you think that device will have any place in such a patient.
Again, I don't think I can talk Dr. Bobby Harris into another one of these in her, but the or our structural heart team. But I don't know. I'm not aware of that particular device. I don't know if you want to describe that.
Oh, okay, it's undergoing some clinical trials that look pretty reasonable. Actually, our former cath lab tech, Joe Brown, is a principal in this company that makes it, and it's literally what I said. If the left atrial pressure goes up, it releases pressure to the right, but it doesn't create a permanent ASD. But as you get episodes of high left atrial pressure, it'll pop off into the right atrium. So, I don't know. It's early in the evaluation, but we'll be hearing about it in the next 6 months, I think.
Yeah, I mean, clearly the devices for mitral valve disease and the pumps and temporary pumps are getting much better. I mean, I think the first question we as a heart failure group or society have to do is try to differentiate those patients who really we cannot help, and those patients who are more stage C, where we can really make interventions that can improve their short and long-term outcomes.
Spencer, I think that trial is initially for patients with diastolic heart failure, at least the one that we were approached about. I think the algorithm is, if they have a PFO, you close it, and if they don't have a PFO, create an ASD. And, no, just kidding. And then see if you can improve their symptoms. So, as far as the Entresto, I want people to be aware that we have a clinical trial going on in the Heart Failure Network. Only 5% of patients in the Paradigm study had class 4 symptoms of heart failure, and there's a question as to whether patients with really ongoing severe symptoms who physicians may be a little bit reluctant to start on the medication, whether they benefit or not. So if you have those patients in your clinic who have ongoing class 4 symptoms most of the time and have signs of fluid retention, and you're wondering whether they should go on the drug or not, out of concern, consider referring them for this trial where we're randomizing those patients to ARB versus Entresto. So, Raja, that was fantastic, very organized, and great thought processes as always, and going through the different scenarios that came up with this patient. Thank you very much.
The preceding program is copyrighted by Emory University.